Hello, dear students. Good evening. So, welcome to today's class. So today is Farre for fourth year prof, and today we are going to deal orthopedics. And in ortho, though, we are going to deal with infections and oncology. Two important chapters which are very for your theory point, right? So, are you ready? Hi, Dr. Prakash. So in this today's class, we are going to deal with two important topics as I've mentioned. So one infections, second one is your oncology. So I have picked a few important questions which are usually repeatedly asked in the exam. So that is regarding to the osteomyelitis, where we have two types of osteomyelitis. Both of them are important. Is your acute osteomyelitis, the chronic osteomyelitis. And next one is the other very important chronic infection, that is your tuberculosis. So in that, the TB spine is supposed to be the most important. And then coming to the oncology part, that is the tumors, we have benign and malignant. So from the benign part, we have giant cell tumor, which is important, and then in the malignant part we have osteosarcoma and Ewing, which has been. So today we are going to understand and uh, read these topics, and if at all they come in the exam, we are going to write it in a great detail. Okay, so osteomyelitis as such is infection, as you all know. Osteo meaning bone, myeli meaning your marrow, and itis is inflammation. So this is due to this inflammation of the bone and the marrow is because of infection. And as you all know, this infection can be in two forms. So first form is infection type is, I think we need not repeat what is acute and chronic, because you're very well versed from your year of pathology, where the infection is less than 2 weeks is acute, and if it is more than 2 weeks, right, is said to be a chronic infection, right? So first, let us deal with what is called as an acute pyogenic osteomyelitis. So we very basically know all the meaning of all the terms. So acute is very less than 2 weeks. Pyogenic means pus forming infections, and osteomyelitis is I have already explained. You're going to write that as a definition exam. So we know the pattern, right? Always we will start with the definitions. We will write what is an acute pyogenic osteomyelitis. Then whenever we say it is an infection, bone and marrow. So here you have to understand by microorganism, right? Then who are these microorganisms, right? Then you have to understand what are the causative microorganisms, and then we will understand how will they enter our body, right? So causative microorganisms, usually, most commonly, most importantly, in case of ortho, it is staph. It is staphylococcus. This is very important. This is important in case of it also. So infection first organism is your staphylococcus aureus. Then what are the other organisms? Then we have streptococcus, right? So then we can actually write as in case of newborns. So it is mainly streptococcus, and in case of, again, you can write it as, hi Jasmine. Then in case of IV drug abusers, it is Pseudomonas. Then we have 1 to 4 years of age group. Kelvin Christopher, hi. Hemophilus influenza. So people who have come late to the class, I am just teaching infections, orthopedic oncology today. So we are started with osteomyelitis. Oh, Jasmine, you're preparing for NEET. So I think this is for you then. This is for the people who are appearing for their prof exam. Their prof. But you can still hear the class. It will be like a topic discussion for you. So we are discussing about acute osteomyelitis. So in this, we have come up with the definition. So what is actually osteomyelitis? Hi Kalai, good evening. Fine, how are you? So then we have most importantly in case of sickle cell disease, this salmonella. Salmonella. So these are some of the important organisms which you have to remember. So whatever might be the answer, usually you have to mostly remember this Staphylococcus or staph and ortho are very much related. So most common organism which is causing infection in ortho is your Staphylococcus, right? Then comes the Streptococcus, which is seen in the newborns. Then in case of IV drug abuses, it is as in case of 1 to 4 years, it is usually hemophilus, but because of the vaccination HIV, this has reduced. Okay, and then in case of sickle cell, we have a special bacteria which is involved, that is salmon. So as far as this also has to be remembered. Fine, is that clear? And now let us understand how is this organisms entering our body. So the organism entering our body is always hematogenous route. What do you mean by hematogenous? That means it is always through blood. So what could be the reasons? The reason could be any caries tooth, right? Any skin infection which is penetrating deep into the wound and then it takes the hematogenous route, or any lung infection or any throat infections. So these are the various forms where the bacteria enters through the blood. And now what happens is once the bacteria is entering into the blood, it resides in the blood, and then it takes it root the bone. And in the bone, if you remember, there are three structures, right? So epiphysis, metaphysis, and diaphysis. So in that, our bacteria chooses metaphysis. It's also very, very important to remember. So first, what you will write regarding acute osteomyelitis, you will write the definition, then causative organisms you will write, then the route, how it is entering. So route is always through hematogenous route, right? And then, so this you can put it as pathogens. So once it has entered the bone, now the pathogenesis of that particular bacteria will start, right? So what do you mean by pathogenesis? So pathogenesis is the pathology where it is going to start, right? So why it is choosing metaphysis? So that is also an important question. What makes the bacteria to reside in metaphysis? What makes the bacteria to reside in metaphysis? So there are certain important things which you have to remember regarding the metaphysis. So once you talk about the bone, if you see, so this part is the epi, and this is the meta, and this is the diaphysis, right? Is it, this is all you know, right? And now there are certain vessels which are present in the metaphysis, and they are in the form of hairpin bend. So this you have to draw it in the exam. So you're going to draw this and this. So you will tell this as epi and this as meta. And what you do? You draw hairpin bend. So this is the arrangement of your metaphyseal vessels. So this is what you will write there, right? Yes, very good. Hairpin bend is there. Then what does this hairpin bend do? So this hairpin bend, what does it do? It makes the blood flow sluggish, and it gives the time for the bacteria to multiply or replicate. So it makes the blood flow sluggish because of that bend. Usually whenever we take a U-turn also, we take our vehicle slow, right? So that is how it happens. So the blood flow here is little sluggish. And what is the second thing what you have to remember regarding this? So there is a decrease in oxygen tension. So oxygen tension is also low, and there is also decreased in amount of macrophages. So the defense mechanism is also low, right? So here, and you know that blood is a very good culture medium, right? We all know blood is a very good culture medium, right? So that is why here the bacteria proliferate, the bacteria get cultured. And to its addition, there is low oxygen tension, which is again a good factor, that is anaerobic bacteria. And again, because of decreased macrophages, that is defense mechanism is also low. So these are all the things which will actually facilitate the bacteria to grow there. So that is why the metaphysis is considered as the a very important area for the growth of the bacteria. Okay, these are all the points you have to write in pathogenesis, right? And then they will then you have to remember what is the most common area, most common sites. So usually it is around the knee joint, lower end of femur and upper end of tibia. Lower end of femur and upper end of tibia. So once the bacteria stays there, it replicates, right? So it reaches the metaphysis, and you all know that this is the area where the bacteria proliferate, and we all know the reasons. And now it will initiate the inflammatory response. But for this to happen, the host defense should be low, right? It is not that for anybody the bacteria can enter and do whatever it wants. It is not like that, right? Some people are strong, there are high immune individuals, so in that the bacteria can't do anything, so it will fight, and then the body wins, and then the bacteria dies. But for some people where they are immunocompromised, so there are certain people who are like, suffering with the local factors or systemic factors, right, where their host immune system is low. So what could be those systemic factors? The systemic factors is they could be suffering from diabetes mellitus, so they could be on corticosteroids, or they can be on chemotherapy, right? So these are the various systemic factors generalized, or they could just be malnourished, malnutrition, right? Or local factors where there is wound or ulcer which is residing there, and there is a skin infection which is there, and this local factor is leading uh, yeah, Utkarsh, good evening. So this local factor will lead to more bacteria. So if the bacteria is also more in number, then they will develop the infection. This is what you have to remember, right? So always remember the infection prevails when the host defense is low. So once this bacteria reaches the metaphysis, it initiates the inflammatory response. But remember that the host defense has to be low at that time. And then what does it do? Inflammatory response means what happens? So it will gather all the inflammatory products. So now there is bacteria, then there is influx of the inflammatory products such as neutrophils, macrophages, and all those come and play, and it forms into what is called as pus. So all those infection, inflammatory products, granulocytes, macrophages, all together they form what is called as pus in that metaphysis. And now you have to track this pus. So you can know the tracking of pus. So again, it is depending upon the host defense mechanism. So once if the host defense mechanism is strong, it will maintain the pus at that area only. But again, if the defense mechanism is weak, what will happen? Now there are routes for it, so it might go anywhere it want, right? So it may trickle down the medullary cavity, or it may enter the Workman's canal. To go back to the architecture of the bone it has a straight structures like the Harvesian canals and the Workman structure. Workman structures are something like this. So if this is the bone, these are the Workman canals, and this is the periosteum. right? So these are the, it can trickle down the Workman's canal or the medullary cavity. Sometimes is if the capsule is involved, or the epiphysis is inside the capsule, it might go to the joint also, right? It may go to the joint, which will lead to septic arthritis. And here it might go to Workman's canal and then raise the periosteum, and from there it can go to the skin as well, right? And that is, and when it reaches the skin and form the sinus, that will turn into chronic osteomyelitis, right? Hi Prakash, what do you want me to repeat in Hindi the whole chapter? So this is the beautiful diagram which you have to remember. So this side is acute and this side is chronic. So these two are interconnected. I will tell you acute and chronic together, but in the exam you have to differentiate and write. So whenever you're writing in the exam, the first thing for the acute you write with the definition, write the causative organisms I have, and then you will write the route of entry of the organism, and then you're going to write the pathogenesis. The pathogenesis, first you will always mention about the medullary vessels, the metaphyseal vessels, which hairpin bend, and why this, what does this hairpin bend do to the blood, and why the bacteria cultures there. And then starts the pathogenesis. So what will happen once the bacteria settles in the bone in the metaphyseal region? It will initiate the inflammatory response. So this is like a story. So once it settles down, it initiates the inflammatory response. Again, you have to remember that the host immune defense mechanism to be low for it to initiate an inflammatory. So once the response has been initiated, so the body fights with the bacteria fights with the body, both of them together will form what is called as an pus. So this pus is nothing, it is made of material, it is made of granulocytes. So all this pus gets collected here. And now there are routes for this pus. This pus can trickle down along the medullary cavity like this. It can infect entire length of the that, right? Or else it can walk through the Walkman's canals and it can raise the periosteum like this. So called elevation of the periosteum. So periosteum is a covering of the bone, and this is one which supplies nutrition to the bone, right? So periosteum is a layer of the bone, and whenever periosteum gets irritated, it results in new bone form. So this is one of the most important layer of the. So now what happens is this pus will elevate this periosteum. So once this periosteum is elevated, there is lack of limited blood supply to that particular area, and there is chance of that particular area to be dead, right? So now the bone there becomes dead, and this dead bone, whenever it is dead, this is called as the sequestrum. This is called as the sequestrum. This is called as the sequestrum, right? And as I told you, whenever the periosteum is elevated or irritated, there is a new bone formation, and that new bone formation is called as the involucrum. So that new bone formation is called the involucrum. Understood? So whenever I use the terms sequestrum and involucrum, that means I am talking about a chronic osteomyelitis. I'm talking about a chronic osteomyelitis, right? So in case of acute, what happens is in acute, there is only this pus which is right, and this pus formation takes 10 8 hours, right, from the entry of the bacteria, and then it has to raise the pus. So that is the pus formation is acute. And whenever you see sequestrum, involucrum, and other two important things is once the periosteum is elevated here, it can come up to the skin. So whenever they come up to the skin, that is called as the sinus. It is a tract. Sinus is nothing but a blind tract, the epithelium, right? So this blind tract on the sinus, and there are small openings on the bone. Those are called as okay. These are called as closed. So these are all the features of your chronic osteomyelitis. Okay. Once the pus is formed, that is your acute osteomyelitis. And now you're not treating this pus, not taking care of the pus. And if the host immune mechanism is still weak, then what happens? It keeps on elevating the periosteum. And then the blood supply is cut off to that particular bone. And this will result in a piece of dead bone, which is called as sequestrum. And once there is a irritation to the periosteum, because lifting of the periosteum, it forms a new bone which is called as involucrum. And this pus can track down up to the skin, which is called as sinus. And then there are small openings, this bone, which is called as cloacae, called as cloacae, which is called as cloacae. So these are all the chronic osteomyelitis. So that is about the pathogenesis. So I have combined and told you the pathogenesis of acute. Now coming back to our answer. So now we are here where we are writing the pathogenesis, right? So once we are done with the pathogenesis, the tracking of the pus, that means it can go through the medullary cavity, it can go through the Workman's canal, or it enters the joint cavity. Now the patient will come to us with the certain clinical signs and symptoms. So acute is still we are in the state of pus formation, right? So what are those symptoms where the patient will turn up during the pus formation? So the first one is presence of fever, very much of pain, right? They comes with pain, mild swelling, right? And the most important thing is fever. And then you will have what is called as limitations of movements, right? So these are the clinical symptoms which the patient comes with us, right? So he comes with pain, fever, swelling, limitation of movement. For example, if it is we already know that the femur or the knee joint is right. So now they will have pain while movement of the knee joint, and then they will come with swelling, they pain, then they will have episodes of fever before coming to right. Yeah, limitation of movement is sometimes called pseudoparalysis, but this term is mostly used for septic arthritis. For acute osteomyelitis, is not like the completely paralyzed because it is not the joint which is involved, right? And then what do you do? So once they finished with your presentation, they come with fever. Then what do? You do the blood test, right? You take the history first, then blood test. What blood test you do? So you always start with ESR, ERP, CBP. In CBP, what you will find? In CBP, you will find there is raised neutrophil, right? Right? So in CBP, you will find there is a raised neutrophil. So ESR, CRP, right? And then, so ortho is incomplete without X-ray, right? So we will ask for X-ray, but in X-ray, no changes are usually seen. Sometimes what you can see is soft tissue swelling, right? And after weeks, you can see there would be a reactive sclerosis. Reactive sclerosis. So I'm telling that X-ray is of no use. Then where will you go? What is the next mode of investigation? What you have to do? So we are done with the blood test. Then we have come to radiology. So we have done X-ray. Nothing is found on X-ray. Then we go for MRI. So MRI is supposed investigation of choice where you can track the pus as well. So you will see the edema, and if the pus is, you can see the pus as well. You can track the pus, right? And then you can also go for bone scan with technician 99M methyl diphosphate or indium 11 right? Indium triple 11 or gallium 60. These are for the leukocytes identification, right? These are the bone scans. So bone scan is what? Bone scan is we will inject certain element, right? So we will inject like gallium 67 or gallium indium 11 triple 11 labeled leukocytes or technetium 99. Gallium 60. Right, so these are the bone scan material. So these are the bone scans which can be these are the dyes which are the radioactive dyes which we inject, but usually we don't do it for infections. These are done for identification of the cancers, the metastasis. But if the if you're really very much sure that you can't detect it on the x-ray and right, then you go for the bone scan where you can easily see, because the bone scan is what? It is radioactive. So the cells are very much active in case of infection, right? So the infections are very well detected on bone scan. So what are the bone used? So technetium 99, indium 11 labeled leukocytes, and gallium. They're the dyes which can be used for identification. They're the bone scans, but usually what we do is we go for MRI. For MRI, where you can us for the bone edema. Till we are in the acute stage, right? So then what you do? You have to So once the investigation, you are done with the history taking, then you're done with the blood investigations, then you're done with the X-ray. Yes. Before that, if you're sure, then you start the treatment, because biopsy usually takes time, right? Biopsy is the gold standard. Okay, I understand biopsy is the gold standard, but usually by the X-ray and by the MRI, we can diagnose this as infection, right? So still you're in doubt, then you can go for biopsy. Because why biopsy is gold standard? Because there is one important carcinoma, that is Ewing's sarcoma, which can mimic like your acute osteomyelitis, right? So that is why whenever you are in doubt, what is the one thing which is very very useful to you? Biopsy. You always consider gold standard. But usually in the practice, what we do is we take the X-ray first and then we go for MRI, and based upon this we use treatment, right? So here the treatment depends upon whether the patient has survived less than 48 hours or more than 48 hours. This you have to remember, right? So because if it is less than 48 hours, that means still the pus is not very active. So what you do, you treat with IV antibiotics. IV antibiotics. You have to IV for 2 weeks, then followed by oral antibiotics. And most commonly, what drugs you use? Ceftriaxone, vancomycin, right? So these are the drugs which we use. Usually we treat with the IV antibiotics, right? So IV antibiotics is very very important to treat the bone. Only oral will never be sufficient. You have to go for IV antibiotics and then followed by your oral antibiotics. Before that, you have to always immobilize. So immobilization sometimes with the help of splints, avoid weight bearing for at least 3 weeks, right? And hydration is very very important for patients. And forget that good nutrition. The treatment follow. So first, usually you follow the antibiotic protocol. So what you do is you have to treat with antibiotics, IV antibiotics for 2 weeks, and followed by your oral antibiotics, right? So oral antibiotics we give for 4 weeks. Then, if at all, if the patient has come after 48 hours, that means there is already pus has formed. Then what you have to do? You have to drain this pus. So you go for draining of pus, called as draining of pus. So here, whenever you're draining pus, then you can always send for biopsy. So whenever there is a pus, you have to, after 48 hours, if the patient has MRI, you see there is pus which is present, you go for what is called as draining of eyes, and then you have to completely drain the pus, right? So that is called as the debridement, right? And then you start with your IV antibiotic. Same, 6 followed by oral for 4 weeks, right? And then here also you have to tint, and all these things you have to follow. So they have to have weight bearing, they have to go for good hydration and good nutrition. So this is how we deal with both acute osteomyelitis in case of less than 48 hours and more than 48 hours, right? So that is about the acute case. And then what are the complications? If you don't deal with the acute, or if you neglect acute, or if there is, lot of host virulence, so host the bacterial virulence, then how does it land up? It might land up in, first thing is it goes to chronic osteomyelitis, right? And then it might enter as pyogenic septic arthritis. That means it might enter the joint, right? So it might result in pyogenic septic arthritis, or it may end up in chronic osteomyelitis. And sometimes it might result in, if it goes into chronic osteomyelitis, it will result in growth disturbance in case it results in chronic osteomyelitis, right? These are the two important things which you have to remember. One is your chronic osteomyelitis and pathogenic septic arthritis. That means it enters into the joint, right? And then it might result in growth disturbances sometime. So this is about your acute osteomyelitis. Is that clear? So whenever they ask you about acute osteomyelitis, these are all the things you have to write. So the treatment part and the complications part, and how actually what happens, pathogenesis, then the blood test, right? Here everybody. And then and then let's see what happens in chronic osteomyelitis. So whenever we treat with chronic osteomyelitis, here what happens again, post immune system is weak, whereas virulence, the bacteria. So whenever such a thing happens, like the host immune systems where virulence, and if acute cases not treated properly, if you have neglected any antibiotics, or the dosage, or proper treatment has not been done, then these patients will end up in chronic myelitis. So the word chronic means it is almost more than 2 weeks, right? So the infection has started and it is more than 2 weeks. Now what happened to the bone? We already have discussed. So in chronic case, again you have to put, in chronic case mostly everything is same. The organisms is same. The root is in hematogeneous, but what is the pathology? Pathology differs here. So the pathology here starts with the, that is the whether, what are the reasons for it to convert into chronic. So first one could be the weak post immune system, or increased bacterial virulence, or if acute cases are not treated properly, will result in your chronic osteomyelitis. So here what will happen, as the bacteria is proliferating by itself, it is continuously lifting off the periosteum. So once the periosteum is lifted off, I have told you that it results in thick vestrum. So it results in sequestrum. Now, what is a sequestrum? A sequestrum is a piece of dead bone identified by dense sclerosis on X-ray, which is surrounded by granulation to present as lucency on X, right? So this is a piece of dead bone, so it is white and it is identified as a dense sclerosis, but it is surrounded by a granulation tissue. Now this appears as a lucent structure. So now here you can identify, so this is your sequestrum, and this sequestrum is appearing dense. Now can you tell me why the sequestrum is dense white in color? Yes, Kalai? Why the sequestrum is appearing white in color? Why not dark in color? Yes, my question is why the sequestrum is appearing dense. Why, I mean, like, why white, why not dark? Actually, if it is dead, if at all, take it as like avian, it appears dark in color, right? So whenever something is dead, the blood supply to it is cut off, right? So even in the avian also it appears sclerotic. So why it appears white in color is whenever the blood supply is cut off, resorption, bone resorption is lost, right? So bone is a dynamic structure, right? There is bone formation and bone resorption. So whenever this vessels, the blood supply to it is cut, the resorption is lost. And when this resorption is lost, it appears dense white in, it appears as a dense sclerotic, right? Is that clear? So that is about the sequestrectomy. Sorry, that is about the sequestrum. And now we will deal about involucrum. So what is involucrum? So in involucrum, what happens is here involucrum, we already know that the periosteum is irritated. So whenever there is an irritation of the periosteum, it results in new bone formation. So it results in new bone formation, and this new bone is called as the involucrum. And now because of this, there are certain openings on the bone. These are called as cloacae. These are called as cloacae, right? So you have to put all these words whenever you're dealing with chronic osteomyelitis. First is sequestrum, then you write about the involucrum, then you write about the cloacae. So openings on the bone are called cloacae. And now this pus, as I told you, will find its way from the bone, the skin. Now what will happen here? It will discharge bony white PQ, right? So this is a characteristic feature of the chronic osteomyelitis. So you have to put all these words. So first you are starting the you start chronic osteomyelitis as the why it has landed up in chronic osteomyelitis. Then you will write the pathology. So the pathology here is, we already discussed that the blood supply will cut off and this will result in sequestrum, new bone formation, involucrum, openings on the bone which is called as the cloacae, and then this pus sometimes will find its way from the bone to the skin, discharging bony white spicules, and this is called as the sinus. Called as a sinus or the sinus tract. But the most important thing is, what is it discharging? It is discharging bony white spicules. It is discharging bony white spicules. So that is about your chronic osteomyelitis pathology. Now X-ray or the clinical features. So the clinical features, what you see, the patient comes again with severe pain, swelling, and this time he comes with the sinus tract. So they could be one or multiple, right? And then he will tell you that white bony discharge is present and he looks malnourished, right? And there would be some loss of weight because it is a chronic thing, right? And loss of appetite. These are all the clinical features where the patient usually come. But here what happens is, the pain is very, very minimal. Usually they present with the sinus tract. They usually present with the sinus tract. And now on examination, you can find that bone appears to be irregular, right? You find that bone is irregular, skin is puckered or change in color. Then you will find sinus tracts, right? So these are all the things which you can find on the examination. Then what you will do? Now what you do? You ask for the X-ray, right? On the X-ray, what you see? You see the patchy sclerosis, and then you see your favorite sequestrum. Then you will identify your involucrum, and sometimes you can small openings you can see on the bone, right? This is all you see on the X-ray of the bone. So this is what you see on the X-ray. You see there is a patchy sclerosis, right? So there is some amount of sclerosis here and there, right? And then you will see that this is the sequestrum, and this is covered by a lucency, that is a granulation. Then you can see some amount of new bone formation, right? That is your involucrum, right? So these are all the things which you see on the X-ray. This usually confirms the diagnosis of your chronic osteomyelitis, right? And then what do you do? The treatment. Treatment is nothing but, here the most important thing is, you have to remove the nidus. So removing the nidus is nothing but sequestrectomy. So you remove the sequestrum, that is your sequestrectomy. And then you convert the nidus into a saucer shaped structure, because you don't want this to be like this. So here what happens, there is lot of pus which is there, and now you have to drain this entire thing, and once you have drained it, again it forms like a cavity. So you don't want that to happen. So what you do, something like this. So whenever something is collecting, it goes away like that, right? So there will be collection like this and it goes away like this, but here the collection comes and cannot go like that, right? So this is called, what is called as saucerization. So converting the cavity into saucerization, and then you have to close the cavity as well. So you can do with muscle transfer or with a bone pieces, right? So you close the cavity, and sometimes you can do continuous irrigation. It's called continuous irrigation and suction. These are all the procedures which we do. And in case of acute osteomyelitis, what I told you, draining of the pus and debridement, no? So this draining of the pus can be done by putting the holes. So multiple drill holes we will make in the bone. So if this is your bone, so we will make multiple holes in that bone. So they will put holes like, so that the pressure is decreased, whatever the pus is there, it is drained. So sometimes we can make a single hole, big hole, and drain the pus, right? So that is for acute. And for chronic, there are various procedures. What we do is first remove the nidus, that is sequestrectomy. Then you convert the, not the nidus, you convert the cavity into a saucer shaped, that is your saucerization. And sometimes you can close the cavity with the help of your muscle transfer, so you can your bone pieces, or you can do what is called as continuous irrigation, the continuous irrigation and suction which is happening. Okay, that is about the treatment. And not to forget, all this is with IV antibiotic, right? Plus rest plus printing, right? So this is very, very important. You have to treat the IV antibiotics, you have the rest and printing, right? And then, and now this also you can send it to the biopsy, right? Sometimes this might land up with amputation also, right? In some cases you can land up, you can treat with the amputation or excision of that particular part. One is in excision of that infected particular bone, or but usually what we treat with this uh, sequestrectomy and saucerization technique, and then we go for continuous irrigation, right? So now what are the complications? So these are called exacerbation. So exacerbation is once there is an chronic osteomyelitis, and then there will be recurring episodes on it. So exacerbation of your chronic osteomyelitis, and again they can lead to growth disturbances. The most important thing, amyloidosis. They can result in what as your amyloidosis, right? And then they can land up in joint infections as well, or they can result in pathological fractures, right? So these are all the things. And one more important thing is sometimes they can land up with the sinus tract malignancy. So whenever you're dealing with the chronic osteomyelitis, what you have to do is you have to excise this sinus tract, as they can result with sinus tract. You have to excise the sinus tract. So these are the some of the complications of your chronic osteomyelitis. Yeah, guys, are you following? You're there? Yes, all who have followed both osteomyelitis, acute and chronic, give me a thumbs up. Yes, Kalai. Prakash, Kalai, Jasmine, Calvin. Is it fine? You have any doubts in osteomyelitis? Yes. If it is clear, then we are moving on to the next infection, that is your TB spine. That is your TB spine. So in TB spine, what is most important thing is, again, it is tuberculosis, the most important bacteria, the chronic infective bacteria, which is called as the, it is your mycobacterium tuberculosis. Right, so this is your mycobacterium tuberculosis, which will result in the infection of the spine. So this mycobacterium tuberculosis is a chronic infection and usually involves spine followed by hip. Right, why the name as mycobacterium? Because of the presence of which substance in the cell wall? Yes, it is because of presence of your mycolic acid, right? So mycolic acid is present in the cell wall of mycobacterium. This is stained by which stain? Color you left? Zn stain, right? Zeal-Nielsen stain. So that is your Zn stain, right? That is your mycobacterium tuberculosis. And in the spine, usually there are types. So in the type, the most one common is your paradiscal tuberculosis. Why paradiscal tuberculosis? So this diagram will tell you. Because the supply of the vertebra to the spine is like this. So a vessel enters and it enters the lower end of the vertebra and then the upper end of the vertebrae, because the disc is an avascular structure. So because the blood supply is that way, that is why the paradiscal is most common. And what is the important root? Again, this is always secondary. Root is hematogenous. So what are that hematogenous roots? Which plexus? Batson plexus of veins, right? So Sarosh, this is NEET PG, not UG. Okay, fine. So the root is secondary here, and what I have told you, the most common spread is hematogenous spread, and this is through the Batson plexus of veins. So Batson plexus of veins are the thoracic plexus, right? So the thoracic plexus which are connected to the lungs and the your vertebrae. And here you have to remember that the most common spine which is affected is the dorsal vertebrae, right? So again, the reason being your Batson plexus of veins, because it is connected to your thoracic vessels and the vertebrae. So the most common one is again your dorsal vertebrae, right? And then, so this is the first thing you have to answer. So you will write the TB spine, the most causative organism or the organism which is involved is the Mycobacterium tuberculosis, and usually it is seen in spine followed by hip. Next part. And the types, the most common is paradiscal TB. So why it is paradiscal TB? Again, because of the arrangement of the vascular supply. When we go back to our anatomy, the basic formation of the blood vessels, where you can see that the blood vessel supplies the one vessel which enters into the lower end and the upper end of the vertebra, which is around the disc. Usually, the disc is avascular structure, right? And it receives its nutrition from end plates. So, once there is an infection which is occurring in this upper and the lower vertebra, so the infection prevails at around the disc, which is as paradiscal TB, and it causes the destruction of the discus, right? And how does it spread? It spread by the hematogenous fluid, and these vessels are called the bats and plexus of veins. And most common vertebra which is involved is your dorsal vertebrae. And again, there are types of TB spine. So first one, if it is and this is paradiscal. What I've told you, this is paradiscal. Then you have central, which is center. Then you have anterior, where the anterior part of the vertebrae is involved. Then you have posterior, where the posterior elements are involved, and this is very rare. And this is supposed to be the most common. Understood? So this is your types of TB spine. So types of TB spine, I've told you the most common is paradiscal. I've told you the reason why. Then what are the other types which you can? There's one. So the second one is called the central, where the center of the vertebra is involved. The third one is called the anterior type, where the anterior structure. So these are all the anterior structure. The half of the vertebrae is involved, right? And this is the posterior tuberculosis, where the pedicle, the facet, right? So these are the types of tuberculosis. And then next, what do you write next? So pathogenesis, right? Yeah, bye, good evening. So in case of pathogenesis, again, because of there is a blood hematogenous spread, the bacteria settles and it again forms incites the inflammatory response. So, but you all know that the difference of this inflammatory response entirely different in. So here, whatever I say, inflammatory response in case of your osteomyelitis, that is involvement of the neutrophil. Then in TB, which cells are involved? Now I want you all to answer. TB, which cells are involved? Tuberculosis. Which cells are involved? So in acute osteomyelitis, I told you it is pus, which is of neutrophil. So here it is. Yes, specific. You have to write this in the exam. Very good. It is lymphocytes. It is lymphocytes. So the lymphocytes are involved. And what is the peculiar thing about TB? See what is called as formation of, on biopsy, what do you see? Formation of granuloma, where you have what? Caseous necrosis, which is surrounded by your lymphocytes. Yes, very good. So we have granuloma, which are caseous necrosis, and then they're surrounded by your lymphocytes, right? And what are the giant cells? So you can also see Langerhans giant cell, right? So these are all the in pathogenesis of the tuberculosis. So now the bone goes into the cancellous structure, that is your vertebrae, and there it creates the inflammatory response. And now what happens here? There is formation of the abscess. And what is the peculiar thing of TB? This abscess is called as which abscess? Specific name is given to the abscess which is seen in tuberculosis. Yes, it is called the cold abscess. Why it is called the cold abscess? Because all the features of an abscess are absent. right? And this cold abscess can trickle down an important structure which is called as muscle. This this abscess will travel down an important flexor of the hip joint. What is that abscess? It would result in, yes, Kalai, where are you gone? Which muscle is involved? Yes, very good. Psoas abscess. Perfect. So this is the pathogenesis of the TB. So this will result in inflammatory response which will cause us granuloma, and this will cause the destruction of the bone, right? And this destruction can be seen in the form of wedging, right? And sometimes you can find deformity such as gibbous, knuckle, right? So this destruction of the bone will result in wedging, right? Wedging of the bone. And then it can also travel down, that such as an abscess, so cold abscess, and it down the psoas, which is called as psoas abscess. So this is all the pathogenesis which will happen in case of your tuberculosis. Now, how does the patient present? What are the clinical features of the patient? So patient will come with fever. Does he come with fever? The most important thing is pain and night cries, right? So because whenever he sleeps, yeah, fever, which type of fever this is? It is a low grade rise of temperature. And now he comes with the pain in the back, and these are specifically associated with the night cries because the contract, I mean the whatever the muscles, the lumbar muscles will be contracted, so protecting the spine flexion, right? So once the vertebra is straight like that, the muscle takes the full what do you say, the muscle is completely contracted and it will put the spine straight so that the patient will not experience any pain. Once the patient sleeps on the bed, what happens is this muscle gets relaxed, and now the whatever the vertebra is there, then now it will rotate on its own and it will flex on its own. So whenever there is a movement in that vertebra, then the patient will have pain. So these are called typically as the night cry, right? And usually at the night time, as we sleep, the body gets relaxed, so the muscle also relaxes, and then the patient will feel the pain. And on the morning, what happens? The muscle gets so stiffened so that it will not allow the movement of the vertebra. And then they will have fever, which is supposed to be a very low grade fever, and that is usually seen in which we call rise of temperature. So these two are very, very specific. And then they will have loss of weight, and then they will have loss of appetite. Loss of weight and loss of appetite. These are the two important. Always look for people, and they will usually look nourished. They usually look malnourished, right? These are the clinical signs and symptoms which the patient will present. And now what do you do? So you will examine the patient and you will call for blood test. Again, you go for CBP where there is an increased lymphocytes, right? And then you go for CRP, ESR where they are raised. Though they are acute phase reactions, but in case of tuberculosis, an increased ESR specifically, right? So this is very, very important. This is very important. You see ESR in case of tuberculosis. So these are the blood tests. Then we call upon the X-ray. So X-ray, you usually go for dorsal spine with whole spine screening, AP and lateral. So here, what are the X-ray findings? So X-ray findings, there is a destruction or loss of disk space, right? You can't see the disk space. There is a loss of disk space. And then you see wedging of vertebrae. Lysis of vertebrae. And sometimes you can even note the abscess on the X-ray, which are seen shadows called as redness, like dark shadows on the X-ray. So these are all the X-ray findings which you see. You see lucency, that is the vertebrae becomes lucent, and then you see loss of disc space. These are all the things which you can see, right? So you can see it's lucent, something like that, and you can see loss of the height. That is nothing but the wedging. So there will be loss of the height of the vertebrae, right? So that is loss of height of the vertebrae here. So now you see, so this disc space is completely involved. So there will be loss of the disc space. Then you can see there is a loss of the height of this particular vertebrae here and here, the AP. And now, actually, we don't confirm it by the X-ray until and the abscess, and what we go for is an MRI, which is investigation choice. On the MRI, you again see this feature. This is again, you can see there is complete loss of the disc, and you can see destruction of the vertebra, right? And sometimes you can see the pus is tackling like this. And whenever you see involvement of the one vertebrae, this is called as knuckle. Deformity of one vertebrae is knuckle. Vertebrae is called gibbous. C is called kyphus. So what deformity is usually seen in TB? It is kyphus, right? So kyphosis you see in the tuberculosis. This is the typical MRI which was given in the exam as well last. So you see there is a deformity or there is a hunchback in case of tuberculosis. And this usually occurs whenever there is involvement of three or vertebrae. So this is called as kyphosis. So forward bending of the vertebrae is called kyphos. Lordosis, there will be loss of lord, right? So this is the X-ray and MRI find. So MRI is the investigation of, and sometimes for biopsy as well. So again, you have to remember that the gold standard for detection of the tuberculosis. Okay? Detection of the tuberculosis. That is how X-ray and MRI very important. And once you are done with the X-ray and MRI, then you go for the treatment. So what do you think is the treatment of tuberculosis? What do you think would be the treatment for tuberculosis? So usually we all know that tuberculosis we treat with AT, right? Antitubercular therapy, right? Yes, very good. It is ATT. But this usually we have to go for 9 to 18 months of and not to forget your ATT always starts first with rest, then you go for ATT, then good nutrition always, right? Then stint. And here, do you think go for surgery in all cases? So previously they used to go for surgery. So they used to open up, they used to remove the pus completely, and they used to debride it. Now we are following what is called as a middle path regime. What is this middle path regime? It is developed by our own orthopedic surgeon, SMHU Banaras Hindu University. Has done extensive research on this. Now he has come up with a middle path regime where you treat most of the cases conservatively, right? You don't go for surgery, for conservative. In that conservative treatment, what do? You treat the patient with rest, ATT, good nutrition. You splint the part. So what are the important splints we use? We use the Taylor's brace for splinting, right? And then you have certain signs. So what are the signs called? These are called the red flags. So you give all the patients the middle path regime, but you have to identify the patient who is not responding or who is landing up in paralysis or involvement of bowel and the right. So these are some of the red flag signs which you have to remember. If the patient is not responding properly, or if it is even worsening, or they have resulted in paralysis, right? So if there is an immediate bowel and bladder involvement, then you go for surgical treatment. For surgical, otherwise you treat all the patients conservatively, but remember the ATT should be given for 9, 18, right? Now what are the various surgical procedures we have? So most one is your anterolateral compression, decompression, ALD. It is called ALD, anterolateral decompression, or you can go for costotransversectomy. So what is anterolateral decompression? So you had removing a you so this is mainly because of the pus which is tracking down, right? So what you do, you open up the spine and then you remove all the pus. That is nothing but your decompression. So if you're unable to do the ALD, then you remove the rib and the transverse process. So that is called as your costotransversectomy. Or sometimes go for fixation above and below. Debridement. And there is one more called Hong Kong operation, which is a lengthy procedure, right? Just remember that there is Hong Kong operation where there is a thoracic debridement. So complete thoracic cage is opened. The patient is, and then you go for, sometimes you can go for fixation of the spine and debridement, costotransectomy, lateral decompression. These are all the surgical procedures which are used for your tuberculosis spine, right? And then what are the complications? So these patients, whenever are not treated, I end up with in paraplegia. So this is one of the most important things which may happen. So they might end up in TB spine paraplegia. That is about the tuberculosis spine, which you have to write in detail. So starting from definition, so why TB, which mycobacterium tuberculosis, the bacteria, then what are the types of tuberculosis, then the pathogenesis of the TB, what all happens especially, and how the patient presents with clinical signs and symptoms, and how do you investigate with the X-ray and MRI, and how do you treat patients. These are some of the conservative treatment by the ATT, and then you have your surgical procedure. So that is about your TB spine. Then comes oncology. So now let's deal with oncology. The first one, in case of benign, we have the giant cell. So this is usually a 5 marks question. It's a giant cell tumor. So how do you start with giant cell tumor? Do you think is it an benign tumor or a malignant tumor? Yes, is it a benign tumor or a malignant tumor? Yes, GCT is also called as osteoclastoma. The benign or a malignant? Yes, it is a benign tumor, but it is a separate entity where this is called as a benign aggressive. So what do I mean by aggressive tumor? Why did I tell the term benign aggressive tumor? because we are very much worried about the recurrence. So hence it is called as a benign, not infiltration. The recurrence rates are very high. Hence it is called a benign aggressive tumor, right? So it is a separate category. It is not a benign category. Malignant, it is a benign aggressive tumor. So how does this tumor, the origin, the cell of origin is your osteoclast. But there are some theories around it. Okay, so for now, let us remember the osteoclast is the cell of origin. Hence, this is also called as osteoclastoma, right? So this is also called as your osteoclastoma or a giant cell tumor. And where is the cell of origin is done? And then where it is seen, part involved. So mostly it is seen around the knee joint, then your wrist. So in the knee joint, lower end of femur, more common than upper end of tibia, right? Then your lower end of radius. These are the areas where it is already very much seen, the parts of involved, and then it is location, very, very important, and you all know. Oh, location of GC is, what is the location of GCT? It is epiphyseal, right? Epiphyseal in location, right? And now comes the pathology. So this is a type of lytic, yes, facial, correct. It is a type of lytic tumor. And on the biopsy, you see, what do you see on the biopsy for giant cells? Right, you see giant cells, right? You see giant cells plus your epithelioid cells. So giant cells plus epithelioid cells, these are the ones which are seen, right? Yes, very good. So giant cells and the epithelioid cells on the biopsy, it is a lytic type of tumor, and hence because of its lysis on the X-ray, it is seen as what? Which appearance on the X-ray? Because of the lysis, septae, it gives appearance of the soap bubble appearance, right? So it gives a soap bubble appearance on the X-ray. That is the pathology where you see giant cells and epithelioid cells which are surrounded by the epithelioid. Oh my god, Praveen, sunburst is osteosarcoma. This we are in osteoclastoma. GCT is soap bubble appearance, not sunburst. Soap bubble, right? And then how the patient presents with clinical signs and symptoms. Patient can present with pain, bony swelling, right? Usually presents with pain and bony swelling and difficult to bear weight, sometimes with a pathological fracture, right? And here what we do, here usually we can identify the giant cell by the X-ray. On X-ray what you see is epiphyseal encroaching onto the joint, right? It is epiphyseal encroaching onto the joint and it is lytic with multiple septae, which is again giving your soap bubble appearance on the X. And one more important feature is eccentric. What do you mean by eccentric? So now if this is your, you see to one one side, right? Not in the center, one side. And it is very much expansile, right? So eccentric, expansile, epiphyseal, all these are the features of your giant cell. So now it appears as there are septae here like this, right? So this appears as the soap bubble. And now on the x-ray you see, you take the after seeing the x-ray, you confirm this as soap bubble appearance, and then you go for biopsy. On the biopsy you see giant cells and the epithelioid cells, which the diagnosis of a giant cell tumor or osteoclastoma, right? So this is all you're going to write in the exam. And now once you confirm by the x-ray, what do you go? How do you treat it? Treatment is very, very important, right? So here I have told you that this is a benign tumor, but here the thing is, it is a benign aggressive tumor. So whenever it is benign aggressive tumor, the treatment is extended curettage. So usually for benign things it is curettage, but here it is extended curettage in case of your giant cell, right? So extended curettage means what you do? You do curettage plus you put some liquid into it, right? So liquid agents, liquid adjuvants we called. Liquid adjuvants. So what are these liquid adjuvants? So we can use liquid nitrogen, or we can use so these are the liquid things which we put. So curettage, and then we do excision. So the treatment of the giant cell is extended curettage. This you have to remember. It is extended curettage with, what do you mean by extended curettage? So this is the cavity I've told you, right? So we open this cavity, then we curate all these particles in this. After curating all the particles, we put liquid into it. So the liquid nitrogen or bone cement, so that this will create heat, and now the bone cells will die, and this will prevent the recurrence. So we are very much worried about the recurrence. Hello, Aditya. So that is why the treatment for this is your extended curettage. This is very, very important. You have to, right? So that is about your giant cell tumor. So usually it is a small case, right? And now, what are the surgical procedures? So once you do extended curettage, so in case of a very areas where you can't excise, so excision you can do where it is somewhere around the lower end of ulna, where it is not involving the joint, right? It is lower end of ulna, you can do excision. But some places like your knee joint, lower end of the femur, there are certain procedures which we can do. So this is called as turnoplasty or filar grafting. This is the diagram. So if you see here in the lower end of the lower end of the femur, we have the GC. So here what we do, we usually do curettage, but if the bone is lost completely, then what we have to do is we have to take the tibia, cut the tibia into half, and this upper half and lower half we will combine it, then we put the implant. So this is called as sternoplasty. So you take the part of tibia from here and then you cut this into halves. Then you put one half above, one half, or you can do just a fibular grafting. So you will place the fibula, you cut the fibula and place the fibula, or sometimes you can completely replace it. So this is called joint replacement, right? Totally replace. So these are the procedures which are there for treating your giant cell. But usually the treatment what we do is your extended curettage. Very, very important. And other surgical procedures where it cannot be done by only extended curettage, you can go for turnoplasty or a fibula replacement. right? So that is about your giant cell tumor. Okay, giant cell tumor or your osteoclast. Yes, Aditya, you can watch this, but probably you will not gain anything from it because it's all just the revision which we are doing for the people appearing for pro fourth prof. But if you're still interested, you can. Okay, that is about the giant cell. So giant cell tumor, you're going to understand. First important thing you have to put is the benign aggressive tumor. That is why, because for this recurrence, right? And then the cell of origin is osteoclast, and the parts really most commonly seen is knee joint and the wrist. And then the location is epiphysis. This is very, very important. And then this is lytic type of tumor. On the biopsy, you see the giant cells, right? And then the clinical features, the mainly they present with pain, bone swelling, and it is usually not very common to see with pathological fracture, but they present with pain and bone swelling. On X-ray you take, you see all these features, and then you go for treatment. Most important treatment you have to maintain the extended attach, and then there are surgeries where you go for excision. If the joint is not involved, you can go for excision, or if the joint is involved, you can do certain procedure which is called as sternoplasty, tubular grafting, or okay. So that is about your giant cell tumors. So the next one is Ewing's sarcoma. Next one we are going to deal this with Ewing's sarcoma, right? So what is Ewing's? So Ewing's sarcoma is a very, very important tumor, right? So here the importance of this tumor, it is usually seen in case of first decade. Yes, very good. It is a diaphyselinoma. It is usually seen in first decade. That means it is usually seen up to 10 to 20 years of age, right? And then one more thing which you have to the origin. It is a origin of the cell origin is from the neuroectodermal, right? And it usually involves marrow, right? So bone biopsy is very, very important, right? And then location, yes, this diaphyseal, right? Diaphyseal in location. And then most important location or part involved, again it is most commonly seen in the femur, and right. Femur most common, that is the thigh bone. Then pathology, so this presents as a small round blue cells, right? So it is completely small and round blue cells, so it is entire sheet of blue cells which you biopsy. That is about the Ewing's sarcoma pathology. So small round blue cells, and there is a certain immunochemistry, like it is pass positive. That all you have to remember for biopsy. So what are those things? So it is pass positive, and there are certain translocations. It is chromosomal translocation, that is T1122 and T2122, right? So these are the important translocations. These are the chromosomal translocations to remember. And then it is also CD positive, MIC2 positive, 99, and MIC positive. These are certain immunohistochemistry things which you have to remember on biopsy, right? So it is one thing from my end is small round blue cell tumor, and it is also called as blue cell sarcoma, right? And it is all the immunohistochemistry that you know better from the pathology, that it is E99 pass and positive, and this translocation is very very important. This you have to mention in the exam, that is 720 and T2122. These are the two important trans which you have to remember, right? And then how does it present? So the presentation is very very important, because this also presents with pain, fever, with raised ESR and raised CRP, right? So what do you think is this presentation looking like? Do you think it is a natural presentation of a tumor? So, right, tumors usually don't present with fever. They present with pain and they present with swelling. But here you will have pain, fever, and when you go for blood test, you will have raised ESR and raised CR. Very, very peculiar, because it is similar to your osteomyelitis. So, this is the area where all the cultures you have to send for biopsy, and all the tissues you're sending for biopsy culture. That means you have to differentiate between infection and, so usually in infection what happens, the cultures are positive, right? Tumors biopsies are positive. So in case of Ewing's, what will happen is the patient will present with pain, fever, raised ESR, CRP, and sometimes with anemia, right? So now you get confused whether this is an infection or a tumor. So that is why in ortho, what they tell, whatever cultures you're sending, any material if you take out from the bone, you're sending it for culture, suspecting it to be an infection, you have to always send it for biopsy as well. And if you think it is tumor and if you're sending for biopsy, you have to be sensitive. So this is one of the thing which we follow, rule, golden rule which we, right? So this is about the clinical signs and symptoms in case of your Ewing sarcoma. And then we go for, as I told you, blood test, again you see ESR and CRP. Then X-ray, you see a peculiar periosteal reaction. Before that, you know the tumor is located in the diaphyseal region. And what is the peculiar periosteal reaction in case of Ewing sarcoma? What is this called? The periosteal reaction is called as, yes, yes, which appearance it is? So this you can draw a diagram. So just imagine as your femur in the diaphyseal, you will see your periosteal reaction. What is this? This periosteal reaction is called as in appearance, right? So this is called as the onion peel appearance, which is seen, yes, onion peel appearance, Ewing's, right? So this is very very important. And now you, this Ewing's onion peel appearance, then you go for investigation of choice, that is your marrow biopsy. So once you confirm that this is Ewing's, yes, it is onion peel, then you go for the treatment, right? So what would be the treatment for Ewing's? So before that, Ewing's is radio sensitive. It is just not radio sensitive, it is very much radio sensitive. Radiotherapy is like They usually tell that ravings usually melts like snow on radiotherapy. But usually we don't treat it radiotherapy, but we go for chemotherapy instead, right? And then go for surgery. In chemotherapy, we use vincristine, right? Adriamycin and cisplatin, followed by, right? So this is the chemotherapy which we follow. Then we go for surgery. Okay. So that is the treatment. Usually we don't go for radiotherapy because radiation induced osteoporosis. Hence we go for chemotherapy and then we go for surgical treatment in case of your Ewing cyst, right? So this is very, very important. And sometimes they may also, they usually go for adjuvant chemotherapy, and sometimes they also go for neoadjuvant chemotherapy. So what is neoadjuvant chemotherapy? They give chemotherapy, then do surgery, then followed by chemotherapy. This before the surgery is neoadjuvant chemotherapy, right? Before surgery. So that is about your Ewing sarcoma. You have to be very, very careful with Ewing sarcoma on mainly about the diagnosis, right? You have to first send it for biopsy, then confirm it, and then you go for treatment. So the treatment may be, it depends upon the chemotherapy, right? That is about the Ewing's sarcoma. Any doubts you have about Ewing sarcoma? So clinical complications, usually it is a very, very malignant tumor, right? It is a very malignant tumor, and there are certain prognostic features for it. So depends upon the prognosis. The prognostic factors are usually the age. If the age is more than 12 years, or if presence with fever or raised ESR, these are all the poor prognostic features for your Ewing's sarcoma, right? And then what is osteosarcoma? So that completes your Ewing sarcoma. And then we'll deal with what is osteosarcoma, etiology, pathophysiology, same clinical features management. So coming to the osteosarcoma, it is one of the most malignant tumor and common, right? And this is a type of cured tumor, right? Second aid, that is your 20 age, right? Or bone. So this osteosarcoma is two types. What you have to remember. And second, primary is direct. Secondary is as a result of any other disease. So what are the other diseases? Could be osteochondroma, radiation, fibrous, right? So these are all secondaries where it results in a disease, and then you will find the osteosarcoma in that. Radiation induced osteosarcoma is common. The cell of origin is osteoid form. And now can you tell me the location? Location of osteosarcoma. Prasad, where has the med student gone? Location, it is mainly seen in the diaphysis, right? It is usually seen in the and then pathology. So this is a tumor where you see of osteoid within highly exotic parenchymal, right? So there are very much cells which are disturbed, high mitosis is seen, but what is important for us is you see osteoid between them. So you see osteoid between them. So there is a bone you can see. So whenever you see bone, it is usually indicative that that is an osteosarcoma. Okay, so that is the pathology. And then clinical features. Before that, what are the various types of osteosarcoma we have? So we have osteoblastic osteosarcoma, problastic osteosarcoma, right? Then we have fibroblastic, and then we have telangiectatic. And this telangiectatic is very worst prognosis, right? This is how you have to remember. So these are the types. And sometimes they even tell you that there is periosteal and paraosteal also types of osteosarcoma. Again, osteoblastic is where you see the formation of osteoid. Chondro is where you see the formation of cartilage. Fibro is something very strange. And then is telangiectatic, that is vessels, blood vessels, right? So the types of osteosarcoma where we see, right? And the most common part, again, this is the knee joint. Only seen in the upper end of, then sorry, lower end of femur and upper end of tibia. Upper end of tibia, right? And then these are the clinical signs and symptoms. So these are the types. And now the patient might present with pain and a swelling, right? No fever, some nothing of that sort. Pain and swelling are usually there. And then we take out an X-ray. We find interesting structures. So there is formation of osteoid, that is bone. And now here we see what is called as the Codman's triangle. This is nothing but your elevation of again your periosteum at one end. So we already know that this periosteum was elevated in case of now it is the tumor. And then the second one is the osteoid forming along the vessels or Volkmann structures, which is called as the sunburst appearance. Called as the sunburst appearance and Codman's triangle. Seen in case of your sunburst or sun ray. Sunburst or sun ray appearance. Yes. That is the X-ray finding what we see, and then we go for higher investigations. So we can usually go for MRI scan, right? And then finally we end up with the for confirm the diagnosis, right? So once we confirm the diagnosis, then we go for the treatment. So what is the treatment protocol for your osteosarcoma? So again, it is neoadjuvant plus surgery. So this surgery is excision, that is wide excision, replacement with prosthesis, right? Replacement with prosthesis. That is again your TCAR, right? So TCAR is one which is very widely used for tumors, right? And then what you have is for chemotherapy. Again, we have your doxorubicin, cysteine, right? So these are the things which when used, and sometimes they also use methotrexate. So these are the drugs which you have to remember to treat the thing. And sometimes if they cannot salvage, then they go for amputation. Amputation, right? Then they cannot salvage them. So this is so there. And sometimes when you can't put the prosthesis, then you can go for, right? So these are the things. So first is surgery with the replacement. Then if not replacement, then prosthesis, and finally you will end up with amp, right? So neoadjuvant chemotherapy, as I've told you again, it is mainly before the surgery where you can downstage or downgrade the tumor. That means you can, the margins can be reduced with the neoadjuvant chemo. That is about your sarcoma. Hope I have covered most of the points, right? So whenever this is what you have to remember is this all when it is local. When it is metastasis, then again it is a complete ball game, right? Again you have to go for aggressive therapy and aggressive surgeries, right? Depending upon the metastasis. So that is about the infections and the oncology part for today, right? And you're going to revise all these things. So osteomyelitis, both acute and chronic, right? Then you have to revise your GCP things and osteo. Very, very, very important, right? For your point of exam. And this is our Farre series, which we have come up with all the subjects. So ortho, I think we are left out with one more class where I will take up the soft tissue affections such as small questions and then nerve palsies. So that's all for today. Thank you so much. Hope this class helps you for clearing your exams. Anything is there, you can connect or contact us again. Alekhya ortho or PW MedEd, right? So that's all for today. Any doubts, any questions, queries, you can. Sorry for today, I have not much interacted with you because every time I'm taking a class, it is going beyond 3 4 hours. So I thought maybe I have to concentrate more on teaching you. So any doubts? So if there are no doubts, then I will wind up the class for today.